A very good morning to all of you. So I'll be taking the lesions of cervix, what all pathologies occur in cervix. So these are the contents of today's lecture. So first of all, we shall start with the anatomy. So from the your knowledge of first year, you already know that cervix is the lower part of uterus, and cervix has got two parts. It has got two parts. One is endocervix, and the outer part is ectocervix. So endocervix is lined by tall columnar mucin secreting epithelium, while the ectocervix it is lined by stratified squamous epithelium, which is non-keratinizing. And this non-keratinizing stratified squamous epithelium is also seen in the vaginal wall. Again, this picture shows this is the ectocervix lined by stratified squamous epithelium, then endocervix lined by tall columnar mucin secreting epithelium, and this is upper part of uterus which is lined by pseudostratified columnar epithelium. Now, this is a histological picture stained with HND. Biopsy is taken from a normal cervix, and you can see that the lining epithelium is composed of two epithelia. So this is multi-layered. So this is non-keratinizing stratified squamous epithelium, and this one is tall columnar mucin secreting epithelium. But you see this bluish appearance of the cytoplasm, it is because of the presence of mucin. So this is multi-layered stratified squamous epithelium, and in the basal layer there is presence of immature squamous cells, while in the superficial layers these are the mature squamous cells. We can identify the mature squamous cells by presence of glycogen in their cytoplasm, and because of this glycogen you can see that there is cytoplasmic clearing. Now next we come to a important concept of transformation zone. So to understand the concept of transformation zone, we should know that at the time of birth, the endocervix is lined by tall columnar epithelium and ectocervix is lined by stratified squamous epithelium. But as the female grows, the uterus grows, so this columnar lining comes to lie on the outer side. It comes to lie in the ectocervix. So due to the hormonal changes, and when this columnar epithelium is exposed to the external environmental conditions, so what happens? This columnar epithelium undergoes squamous metaplasia. So this lining, which was earlier columnar, it undergoes metaplasia and it becomes squamous epithelium, because squamous epithelium is tougher. It can withstand all those external environmental conditions. So this part is known as the transformation zone, because in this part the columnar epithelium has transformed into squamous epithelium. So this is the transformation zone. You can see that this was the original squamocolumnar junction, and in the adults this is the new squamocolumnar junction. So the point in between the original squamocolumnar junction and the new squamocolumnar junction, there is the transformation zone. So again in these pictures we can see the transformation zone. So you see this is cervix in a female, this is the opening, this is the external os, and this pale pink mucosa is the mature stratified squamous epithelium, and this is the original squamocolumnar junction. This is the zone of transformation where there are immature squamous metaplastic cells giving a reddish appearance, and inside is the columnar epithelium. Columnar epithelium, it gives a deep red appearance. Again this is the longitudinal view. This is the endocervical canal, and this is the new squamocolumnar junction. This was the original squamocolumnar junction, and this yellow is the transformation zone. So a question arises that from where do these squamous cells arise? The squamous cells in the transformation zone. So the answer is that they arise from the reserve cells which are present underneath the columnar epithelium. These reserve cells have the potential to differentiate into the squamous cells. So they will give rise to this immature squamous metaplastic epithelium. This is the transformation zone where the columnar cells, they are undergoing metaplasia to form these squamous cells. These are the histological images. So you can see this is the columnar epithelium, and underneath there is a lining of the reserve cells. Then in this image, these are columnar cells, these are the reserve cells which are differentiating into the squamous epithelium. Now here the squamous metaplasia has occurred. So these are all the immature squamous cells. You can see that there is no glycogen in these cells. So this is immature squamous metaplastic epithelium, and this is important because HPV infects these cells, the immature squamous metaplastic cells, while this is the mature stratified squamous epithelium with glycogen containing cells. Here basal cell layer will consist of the immature squamous cells, but the superficial layers, they have the mature squamous epithelium. Now next, similar images are there. This is the immature squamous metaplastic epithelium of the transformation zone, and again this is transformation zone, and this is the mature squamous metaplastic epithelium. So I hope you understood the concept of transformation zone. So why this transformation zone is important? What is the need of studying this? So the importance is that the immature squamous metaplastic cells which are seen in the transformation zone, they are most susceptible to infection by high risk HPVs. So as a result of this is the part of cervix where the cervical precursor lesions and malignancies develop. So the cervical malignancies most commonly occur in the transformation zone. So this is the importance of transformation zone. So again we can see this is the mature squamous epithelium, and this is the transformation zone with immature squamous metaplastic cells, and here dysplasia has begun because you can see that the cells have become hyperchromatic, bit larger in size and with nuclear pleomorphism. So this is a picture of neoplastic transformation in the transformation zone. So this was all about transformation zone and its importance. So because of the lesions, the cervical precancerous lesion and cancers occurring in the transformation zone of cervix, so it is important to sample the transformation zone. So it was developed by a scientist known as Pap Smear. So Pap Smear is a very effective tool for the early diagnosis of cervical cancer. It can diagnose the precancerous lesions as well as the malignancies of the cervix. So first of all, I would like you to focus on this flow chart. This flowchart shows that the columnar epithelium in the transformation zone, it will undergo metaplasia into the immature squamous epithelium. So immature squamous metaplastic cells in a immunocompetent individual, in a normal healthy individual, if there is no HPV infection, it will mature and it will give rise to the mature squamous epithelium. But if a patient is immunocompromised, has certain risk factors, so that individual will get infected with the HPV. So after HPV infection, especially with the high risk HPV, this squamous immature squamous metaplastic cells, they will change into atypical or dysplastic squamous epithelium. So to diagnose these lesions, we need to do the Pap smear. So what we do in the Pap smear, we take sample from the this transformation zone. So now we will see how we take the sample. Before that, this is the scientist, Dr. George Papanicolaou. This question comes in MCQ sometimes. So Dr. George Papanicolaou, he invented this Pap smear. So Pap smear, it is important because it can detect the presence of a pre-malignant lesion in the cervix, and it will allow the prevention of cancer. So action can be taken at an early stage. So how the Pap smear test is done. So in these images we can see Pap smear test. In Pap smear test we take 3 samples. The first sample is the vaginal sample. The vaginal sample we take with the finger. The patient is in the lithotomy position and we swap our fingers through the posterior vaginal wall. Why the posterior vaginal wall? Because the discohesive cancerous cells which are present in the cervix, they will exfoliate and drop down to the posterior vaginal wall and in the posterior fornix. So first sample we take is the sample from the vagina with our finger from the posterior vaginal wall. Then second sample is the junctional sample. Junctional sample, how we take with the IR spatula. This is the IR spatula. This is a wooden spatula. It fits into this transformation zone. So this is the transformation zone we saw in the earlier slides, and this spatula fits into this transformation zone, and we rotate it 360 degree to obtain the junctional sample. Then last sample is the endocervical sample. Endocervical sample, this is the endocervical sample which we take from the endocervical canal. For this there is this brush. This is the endocervical brush with bristles, and this is the handle, and this is the tip of the brush with the bristles. And this brush is the cervix brush. This is a bit costlier than this conventional Pap smear kit, but with this cervix brush we can take both the endocervical as well as the junctional sample in one go. So we will see how. So this is the first video which I will show you. So we put this speculum into the vagina, open it, so cervix is visualized, and then we take the sample. In the next video we see that the patient should lie in the lithotomy position, and they put the speculum. Now this cervix is visualized. The sample is smeared on the slide, and then we put the fixative solution on it so that the smear gets preserved. Now see how they take the junctional sample. So this is the IR spatula. This IR spatula inserted into the endocervical canal, and it is rotated 360 degrees, and after that the sample comes onto the spatula. This spatula is smeared onto a slide so that the sample is transferred to the slide, and then the fixative is sprayed onto it. The third sample will be the endocervical sample. We can use either of these brushes. One is the endocervical brush, which will go into the endocervix and take the endocervical sample. We will do like this in the cervix, and the cervix brush goes like this, and it takes the sample of both endocervix as well as the junction. After that the speculum will be removed. So this is how we take the Pap smear. Next we come to inflammations of cervix. So what is the pathogenesis of inflammation of cervix? Inflammation of cervix is known as cervicitis. So cervicitis can be either acute or chronic. So under the influence of estrogen, the squamous mucosa of the cervix and vagina, it matures, and due to that there is formation of glycogen vacuoles in the cytoplasm. When these cells are shed, this glycogen acts as a substrate for the vaginal aerobes and anaerobes. So normally the lactobacilli, it is present in the vagina, and it produces H2O2, and also it maintains acidic pH in the vagina so that infection does not occur. But in case this acidic pH changes into alkaline pH due to certain factors like bleeding, vaginal douching or intercourse, so that will increase the risk for infections and overgrowth of microorganisms that will lead to cervicitis and vaginitis. So acute and chronic cervicitis is attributable to certain infections like gonococcus, chlamydia, HSV. And in acute cervicitis, what will we see in the morphology? We will see neutrophils. Neutrophils will be seen in the stroma. So this is the stroma. This is the cervical epithelium, and this is the stroma. In the stroma we can see there is hemorrhage, congested blood vessels, and neutrophilic infiltration, and this is the cytological preparation of the same. So when we take Pap smear, we see the squamous cells like this, these polygonal large cells. These are the squamous cells, and these small blue dots, these are the neutrophils. This is the case of acute cervicitis. And in chronic cervicitis we will see the cells of chronic inflammation like lymphocytes, plasma cells, macrophages. And the stroma will additionally show fibroblastic proliferation, because fibroblastic proliferation is the hallmark of chronic inflammation. So this is chronic cervicitis. The inflammatory cells, lymphocytes, seen in the stroma. Next we come to endocervical polyps. So endocervical polyps, what are these? These are just benign exophytic growth. These are just the outgrowths of the cervical mucosa, the endocervical mucosa. These are seen in the endocervix. That's why called endocervical polyps. So this is just the outgrowth of mucosa. So these can be bumpy lesions, and these can also increase in size, reach up to 5 centimeter of size. So the significance of this lesion is that the patient will present with irregular vaginal bleeding and spotting because of these endocervical polyps, and the treatment is surgical removal. So when we take a biopsy of these endocervical polyps, what do we see? We see this polypoidal growth. Polypoidal growth in cross section, and it is lined by the tall columnar mucin secreting epithelium, just like the lining of the normal cervix. And additionally, in the stroma there will be seen the proliferation of numerous endocervical glands. So this is the picture of a endocervical polyp which is protruding out from the external os. Now next we come to the pre-malignant and malignant lesions of cervix. So it is important from exam point of view also. So majority of cancers, they are preceded by the precancerous lesion, and in case of cervix, the precancerous lesion, the precursor lesions, they are known as CIN, cervical intraepithelial neoplasia. So these are the precursor lesions of carcinoma cervix. And the good thing about these lesions is that they may exist for many years before invasive carcinoma develops. So it is said that it takes from few years to more than a decade to develop into an invasive carcinoma if there is a precursor lesion in a female. So during this period, the Pap smear can really help us to diagnose them, and preventive action or curative action can be taken well in time. So the patient will not develop CA cervix. Another important thing is that not all the precancerous lesion proceed to malignancy. Some precursor lesion also regress. So worldwide, cervical carcinoma is the third most common cancer in women. So incidence of carcinoma cervix has decreased because of the effective Pap screening tests. Pap smears, they help in detecting CA cervix at an early stage when it is still curable. So Pap smear, they are like a boon for the early diagnosis and treatment of carcinoma cervix. So next we come to the risk factors for CIN and carcinoma cervix. It is where these factors are important. So since carcinoma cervix is most commonly caused by high risk HPV, it is a sexually transmitted disease. HPV causes STDs. So the risk factors are also related to those. So first risk factor is multiple sexual partners. Then second, a male partner with multiple previous or current sexual partners. Then young age at first intercourse, high parity. Then persistent infection with a high risk oncogenic HPV like HPV 16 or 18. Then if the patient is immunocompromised, then there are more chances that she will develop the precursor lesions. Then use of oral contraceptive, certain HLA subtypes, and use of nicotine are also the risk factors. So the most important risk factor is human papilloma virus. So I already taught you in the last lecture that HPV is a DNA virus, and 50% of HPV infections, they are cleared within 8 months, and 90% they are cleared within 2 years. So if the patient is healthy, she has good immunity, then these infections generally they clear out on their own. But if the immunity is, if she is immunocompromised, or if she has the risk factors, then it will develop into the cervical precancerous lesions. So persistent infection increases the risk of development of cervical precursor lesions and subsequently carcinoma cervix. So most important risk factor for development of carcinoma cervix are high risk human papilloma viruses, and high risks are 16, 18, 31, 33 and so on. So out of this, HPV 16, it is responsible for 60% of cases of CA cervix, while HPV 18 is responsible for 10% of the cases of CA cervix. So this comes in MCQ. So most common implicated HPV for CA cervix is HPV 16. So what is the mechanism involved in viral carcinogenesis in case of CA cervix? So HPV is a DNA virus. So its DNA fuses with the host cell DNA, and it synthesizes certain proteins in the cell. So most important proteins are E6 and E7 proteins. So E6 binds the P53 gene and E7 binds retinoblastoma gene. So you know that both of these genes, these are the tumor suppressor genes. So their function is suppressed by E6 and E7 proteins. It leads to uncontrolled cellular proliferation and decreased apoptosis. So as a result, the cellular proliferation occurs, and it due to increased proliferation, these cells are also prone to acquire further mutations. So it will lead eventually lead to more dysplasia, anaplasia, and increased proliferation in the cervical epithelium, and lead to formation of the precursor lesion as well as the carcinoma cervix. So important point here is that the HPV, it affects the immature basal cells of the squamous epithelium, or in the areas of epithelial breaks, or it infects the squamous metaplastic epithelium of the transformation zone. So we know that HPV infects the immature squamous metaplastic cells, but we also know that in the mature squamous epithelium, the immature cells are present in the basal layer. So whenever there is breach in the squamous epithelium, in the mature squamous epithelium, so the basal layer will be exposed, and HPV can infect the mature squamous epithelium in that case. And so HPV can also infect the immature squamous metaplastic cells in the transformation zone. So these are the two areas where the HPV can infect. So HPV doesn't infect the mature squamous cells. So HPV infects the immature squamous cells, but HPV will replicate and increase in number in the superficial squamous cells. So HPV don't infect the mature squamous cells, but replication of HPV occur in the maturing squamous cells. So these 2 points are important, that HPV will replicate in the mature squamous epithelium and it will infect the immature squamous epithelium. So next we come to SIN. The SIN, this is an important question for exam. Cervical intraepithelial neoplasia. So it has been classified in various ways over the years. So the earliest classification was that it was whenever the dysplastic changes occur in the cervix, it has been they were divided into mild dysplasia, moderate dysplasia, and severe dysplasia, carcinoma in situ. Later on, this classification was, since it was vague, so it was more defined. It was defined more, and it was divided into SIN 1, SIN 2 and SIN 3. SIN 1 means when lower third of the cervical epithelium is involved by the dysplastic changes, so it is called SIN 1. SIN 2, when the lower 2/3 of the epithelium gets involved by the dysplastic cells, and SIN 3, when almost full thickness of the epithelium is involved by the dysplastic cells. So it is SIN 3. And in cytology, we give two terms. One is LCIL, low grade squamous intraepithelial lesion, and HCIL, high grade squamous intraepithelial lesion. So HCIL is equivalent to SIN 2 and SIN 3. These diagnoses we give in the histopathology. So SIN 2 and SIN 3, they are equivalent to HCIL, and SIN 1 is equivalent to LCIL. So in this image, I will try to make you understand what is SIN 1, 2 and 3. So this is the normal squamous epithelium. So here we can see these are the immature squamous cells in the basal layer, and these are the mature flattened squamous cells in the superficial layers. So now dysplasia starts occurring in the lower third of epithelium, then it is called SIN 1 or LCIL. So this is LCIL. The dysplasia means the nuclear pleomorphism, hyperchromatism, scanty cytoplasm, high NC ratio, etc. So this, when it is seen in the lower 2/3 of the epithelium, then we label it as SIN 2. But when it is seen in the full thickness epithelium, we call it SIN 3. When it is seen in almost the full thickness of the cervical epithelium, it is called severe dysplasia or SIN 3. Next stage is carcinoma in situ. In carcinoma in situ, also the full thickness of epithelium is involved. The cells become more and more dysplastic, more anaplastic, and very angry looking, but the basement membrane is still intact. So this is carcinoma in situ. And lastly, invasive carcinoma occurs when the basement membrane breaches and these atypical cells, they go into the stroma, into the cervical stroma. So this is SIN 1, SIN 2 and SIN 3. Next, what is the difference between LCIL, which is equivalent to SIN 1, and HCIL, which is equivalent to SIN 2 and 3. So in LCIL, this is a low grade. So in this, there is HPV infection. The HPV infects the immature squamous epithelium, and there is also replication of the virus. So in HCIL, there is increased cellular proliferation, there is arrested epithelial maturation, the morphological changes, they are more marked, and the viral replication is low here. So here the changes have started occurring, the morphological changes in the cells. So LCILs, the good thing about LCILs is that LCILs, most of them, they regress spontaneously, and only small percentage will progress to HCIL. So LCIL will not even progress to CA cervix directly. Thus only 10% of LCILs, they will progress to HCILs. And so LCIL is not considered as a pre-malignant lesion. LCIL is a precursor lesion of cervix, but it is not a pre-malignant lesion. While HCIL HCL has a risk of progression to CA cervix in 10% of the cases, so it is considered as a pre-malignant lesion. So this is an important difference between LCL and HCL, and the good thing is that the LCL is 10 times more common than HCL. So LCL is more common than HCL. HCL is less common. Again, see this box. So LCL and HCL, 80% of LCLs and 100% of HCLs, they are associated with high risk HPVs. So low risk HPVs do not cause LCL HCL. They are caused by high risk HPVs, and most common is HPV 16. This you have to remember. Next is a table from Robbins. So if some patient comes to you with her report, with her Pap smear report, and there it is written LCL, so you can counsel the patient that there are 60% chances that her lesion will regress, and only 30% chances that the lesion will persist, and only in 10% of the cases it will progress to HCL. So what she needs regular checkups with her doctor, and so that the doctor will monitor the condition of her cervix, so to see whether the lesion has progressed or not. But if the patient comes with a report of HCL, then you have to tell her that it is something to worry about, because 10% of cases they can progress to carcinoma, and she needs more close follow-up with the doctor. Only 30% cases they will regress, while 60% will persist, and 10% there is 10% risk that she will have CA cervix in the future. Now we come to the morphology of CIN. Morphology means how the lesion looks grossly and microscopically. So grossly, see, this is the normal cervical epithelium, the normal mucosa. In low grade CIN, we can see small lesions, very small plaque-like lesions, or they even might not be seen. But in the high grade CIN, we can see the lesions, they increase in size. So they are more suspicious lesions in case of high grade CIN. Now in microscopy, I already told you in the previous class that coilocytic atypia, it is a hallmark cytopathic effect of HPV infection. So this will be seen in cervical intraepithelial neoplasia, and this coilocytic atypia is marked by the presence of nuclear atypia, nuclear enlargement, then hyperchromasia or dark staining of the nucleus, then presence of coarse chromatin granules, nuclear pleomorphism, and there is a perinuclear halo. Perinuclear halo indicate the disruption of the cytoskeleton by the proteins synthesized by HPV. So this is the characteristic change, coilocytic atypia in case of CIN. So coilocytosis, this is coilocytosis seen at high power in the cervical squamous epithelium, and this change is produced with the HPV infection. So HPV infection leads to changes in the cervical epithelium. This is again the summary of CIN 1, 2 and 3. So the CIN 1 means that the lower third of the epithelium shows dysplasia. In addition, coilocytosis. Coilocytosis is more this change is more marked in cases of CIN 1. And in CIN 2, the lower 2/3 will show the atypical cells, and in CIN 3, full thickness of the epithelium is involved by the dysplasia. So this is again the same thing which I already taught you. So these are the images from Robbins, which will make your understanding better. So this is the normal cervical epithelium. So these are the superficial mature cells with glycogen in the cytoplasm, and these are the immature squamous cells in the basal layer. So there is one more point, that these mature squamous cells, they are also showing perinuclear halo, and the coilocytes, they also show the perinuclear halo, but the difference is that here there is no nuclear atypia. The nucleus are round, having fine chromatin, the bland chromatin is there, no nuclear pleomorphism. So this is absolutely benign, while this is the coilocytic atypia with the nuclear atypia. So by this point we can differentiate the mature squamous cells, which also have perinuclear halo, and the coilocytic cells. Now this image shows CIN 1. CIN 1 means the lower third of the epithelium is involved by the dysplastic cells, while in the superficial cells where the viral replication is taking place, here you can see this coilocytic change. So HPV infects the lower immature squamous metaplastic cells, while it replicates in the superficial layer. So in superficial layer you will see more of the coilocytic change. So the next image, this is of CIN 2. CIN 2, it involves the lower 2/3 of the epithelium. and coilocytic change in the superficial epithelium. Here it can be seen. In scene 3, full thickness is involved. So you can see the nuclear pleomorphism, hyperchromatism involving the entire thickness of the cervical epithelium. This is scene 3. And this is carcinoma in situ, where the dysplasia, anaplasia further increases, but still the basement membrane you can see it is intact. And this is the how these cells will look in the cytology. This is the in the Pap smear examination when we see the slides. And this is the normal squamous cells. They seem like this, and this is L cell with the coilocytic atypia. These are squamous cells with coilocytic atypia, and this is H cell, images of H cell, where you can see this nuclear hyperchromatism, increase in the nuclear size, nuclear pleomorphism, high NC ratio here. So this is the cytological, how it appears cytologically. And the last point is that with HPV DNA in situ hybridization, we can also see this proliferation of HPV in the superficial layers of the infected squamous epithelium. So lastly, the key concepts. This is also from Robbins. So cervical low grade intraepithelial squamous intraepithelial lesions, the L cells, are productive HPV infections that usually regress spontaneously, but occasionally progress to high grade squamous intraepithelial lesions in 10% of the cases. While H cells, they are characterized by dysregulation of the cell cycle and increasing cellular atypia. H cell progress to invasive carcinoma in approximately 10% of the cases. And almost all cervical precursor lesions and cervical carcinomas, they are caused by high risk HPVs, most commonly HPV 16. So this is the end of the lecture. So any question you have, you can discuss with me on WhatsApp, and please try to solve these questions which I have given at the end of the PPT. So thank you very much.